Welcome to the Hospital Medicine Unplugged podcast.
Thank you. It's great to be here. Today, we're really going to tackle a major issue, hospital-acquired pneumonia, or HAP, and ventilator-associated pneumonia, VAP.
Yeah, these aren't just complications. They're frankly a leading cause of death from infections picked up in the hospital, a huge challenge for patient safety.
Absolutely. It impacts quality, length of stay, costs, everything.
So our goal today, our mission, if you like, is to really synthesize an actionable, evidence-based approach for all of us managing these patients.
Right. We've pulled together the latest IDS-8's guidelines, looked at key trials like Inspire, which we'll get into in major reviews.
Exactly. We want to give you, the clinician listening, the current standard of care. Not just the guidelines, but the why behind them, the nuances, maybe even some of the controversies.
Okay, so let's start at the beginning. Definitions are absolutely key here because they drive how we think about risk. HAP first. That's pneumonia developing 48 hours or more after a patient's admitted to the hospital. But crucially, they weren't intubated when the pneumonia started.
That 48-hour window is critical, isn't it? It helps us separate a true hospital-onset infection from something the patient might have already been brewing when they came in.
Precisely. It filters out those community-acquired pneumonias that just hadn't declared themselves yet.
Okay, and then there's VAP, ventilator-associated pneumonia.
Right. VAP is distinct. This is pneumonia that occurs more than 48 hours after the patient has been intubated and put on mechanical ventilation.
So the timing relative to intubation is the key differentiator there.
Exactly. Both definitions are standardized, IDS-8s, which helps us categorize things. But it's also important to think about the subtypes within HAP itself.
Yeah, that's a really good point. We often talk about HAP as one thing, but it's not quite that simple.
No, it's not. The most common form is actually NV-HAP, or non-ventilated HAP. This is the one affecting, roughly 1% of all hospitalized patients.
And these are often patients outside the ICU, right? Maybe on a general medicine floor, post-op.
Typically, yes. That's where you'll often see it first.
But what's, kind of sobering about NV-HAP is the mortality. Even without needing a vent initially, the death rates can be pretty high.
They really can. You see figures ranging from, say, 15% up to maybe 30%. It's a huge range.
And that variation probably reflects a lot of things, right? Maybe delays in recognizing how sick the patient is getting, or just the fact that these patients are often quite frail to begin with.
Definitely. Underlying comorbidities play a massive role. These patients are often already compromised before the pneumonia hits.
Now compare that to the other HA variant, VHAP, ventilated HAP.
Right. VHAP is when a patient develops HAP first, and then their condition deteriorates, requiring intubation and mechanical ventilation because of the pneumonia.
So the intubation comes after the pneumonia onset.
Correct. And while it's maybe less common than NVHA overall, VHAP signals a really rapid decline. It carries the highest mortality among these variants. We see rates reported up to, around 29%.
Wow. That really underscores the severity. It's a clear marker of just profound physiological stress.
It is. And these numbers, they really drive home the clinical significance of HAP and VAP overall.
Beyond the mortality, which is obviously devastating, there's huge morbidity. We're talking much longer. Hospital stays often over 15 days median.
Oh, absolutely. And the costs associated with that are astronomical. Plus, it's a major driver for readmissions, especially within that 30-day window.
And for those of us in critical care, it's the single biggest killer when it comes to hospital-acquired infections in the ICU.
It truly dominates the landscape there. So, okay, the stakes are clearly high. Let's talk about the bugs. Who are the usual suspects?
The microbial landscape, It's fairly predictable, but also quite concerning.
Overwhelmingly, it's dominated by two main groups, Gram-negative bacilli and the ever-present Staph aureus, including MRSA.
Right. The literature often refers to the big six, doesn't it?
Yeah.
They account for something like 80% of cases.
That's right. These are the organisms really adapted to the hospital environment. You've got Pseudomonas aeruginosa.
Always a worry.
Definitely. Then Klebsiella species, E. coli, Acinetobacter species.
Which can be incredibly resistant.
Absolutely. Enterobacter species, and of course, Staph aureus, both MSSA and, crucially, MRSA.
For any patient we deem high risk, that's kind of the rogues gallery we need to make sure we're covering empirically.
It is, although it's worth remembering there are others too. Less common, maybe, but still important.
Like what?
Well, you might see Serratia species or Stenotrophomonas multifila. These often pop up in patients with a history of lots of antibiotic exposure or maybe underlying structural lung disease like bronchiectasis.
Okay. And what about the flip side? Are there ever less hospital-like bugs?
Yes, actually, particularly in what we call early onset HAP. So if someone develops pneumonia relatively quickly, say within the first 48 to 96 hours of being admitted, and they haven't had much recent healthcare contact, you might actually find more typical community-acquired pathogens, things like strep pneumonia or Haemophilus influenza.
So the timing and the patient's background really matter for refining that differential.
Exactly. Clinical history is key. But the biggest challenge, I think, in managing these infections up front isn't just listing the potential bugs.
It's figuring out the resistance risk, right, before that first dose of antibiotics.
Precisely. It's stratifying the patient's risk for multi-drug-resistant organisms, MDROs. That decision about empiric therapy, what we start them on, it hinges almost entirely on that risk assessment.
And that assessment needs to factor in local data, our hospital's antibiogram, plus the individual patient's history.
Absolutely critical. So let's unpack those key risk factors for MDROs that the guidelines highlight, because these really form the basis of our decision-making.
Okay, let's do it. What's number one?
The biggest one, the most potent predictor, is prior antibiotic use, specifically intravenous or broad-spectrum antibiotics within the last 90 days.
And we need to ask about specific classes, right?
Yes. We need to know about carbapenems, fluoroquinolones, those high-generation cephalosporins, vancomycin, or other glycopeptides. That kind of exposure creates intense selective pressure. It really shifts the patient's own microbial flora towards resistance.
Makes sense. Okay, what's next?
Second is simply the duration of exposure to the hospital environment itself. Prolonged hospitalization or a long stay in the ICU, usually defined as more than 5 days, is a major risk factor.
So the longer you're in, the more likely you are to pick up the resistant bugs circulating on the unit.
Essentially, yes. The colonization pressure just increases over time.
Okay, third risk factor.
The patient's own microbiological history. If they have a documented history of prior colonization or actual infection with an MDRO, that's a huge red flag.
So previous MRSA, VRE, ESBL-producing organisms, or the really tough ones like CRE, carbapenem-resistant Enterobacteriaceae.
Exactly. If they've had it before, the chances are high they're still colonized. Even if they cleared the infection, it's likely still lurking.
Right. Number four.
The patient's current clinical state and their need for invasive support. Being critically ill, needing mechanical ventilation, having a tracheostomy tube, these things significantly impair natural defenses and just generally increase the risk profile.
Okay, so the severity of illness itself is a risk factor.
Definitely. And finally, number 5 is underlying severe comorbidities.
Things like
Chronic lung disease, COPD, interstitial lung disease, severe immunosuppression, whether it's from high-dose steroids, chemotherapy, being a transplant recipient, active cancer, chronic kidney disease, all these things weaken the immune response and make it harder to clear an infection.
So when you see that constellation, maybe a ventilated patient, immunosuppressed, who got meropenem a month ago, that screams high risk for MDROs.
It absolutely does. And that patient requires our most aggressive, broadest empiric coverage right from the start.
This layering of risk factors is really what helps us separate those, lower risk patients who might just need monotherapy from the high risk ones needing dual anti-pseudomonal cover plus MRSA coverage.
Precisely. It's the foundation of appropriate empiric selection.
Okay, so we know the likely bugs and how to assess risk.
Yeah.
How do these organisms actually get into the lungs and cause infection?
Right.
What's the pathophysiology?
Well, the central event, the primary mechanism for both HAP and VAP, is overwhelmingly microaspiration.
Aspiration of what?
Of contaminated secretions from the oripharynx, the back of the throat, or sometimes from the stomach, refluxing up. Critically ill patients just have impaired protective airway reflexes.
Right, so things like sedation, altered mental status from their illness, maybe recognize swallowing problems or dysphagia.
Exactly. And having devices like NG tubes or feeding tubes, those can interfere with the sphincter at the bottom of the esophagus, increasing reflux risk. All these things make it easier for those colonized secretions to trickle down into the lower airways.
And it's not just the aspiration, is it? The patient's overall state matters too.
Absolutely. Critical illness itself often causes a kind of immune suppression, sometimes called critical illness-related immunosuppression. Combine that with the disruption of the normal microbiome, the microbial dysbiosis, often caused by prior antibiotics selecting for hospital bugs.
So you've got bad bugs taking over, impaired clearance, and easier entry.
Exactly. It's a perfect storm. Pathogens that have colonized the upper airway find it much easier to invade the normally sterile alveoli, set up shop, and cause inflammation and consolidation. That's pneumonia.
And for VAP specifically, the endotracheal tube itself plays a major role, doesn't it? It's not just bypassing defenses.
No, it actively promotes infection. The surface of the tube is like a perfect scaffold for bacteria to form a biofilm.
And biofilms are notoriously hard to treat.
Incredibly hard. They protect the bacteria from antibiotics, from the host immune system. It's a shielded community.
So the tube gets colonized.
Right. And then mechanically, the big issue is the pooling of secretions full of bacteria from that biofilm just above the inflatable cuff of the ET tube.
Even if the cuff pressure is good.
Even with an optimally inflated cuff, tiny amounts of those secretions inevitably leak around the cuff. It's called microaspiration around the cuff. This delivers small but potent doses of highly pathogenic bacteria directly into the lungs below.
So it's this interplay, the device-enabling biofilm, the biofilm shedding bacteria into pooled secretions, and those secretions leaking past the cuff into a vulnerable host.
That's the essence of VAP pathogenesis. It explains why it's such a common and dangerous complication of mechanical ventilation.
Okay, so the mechanisms are pretty clear, but how do we actually recognize these infections reliably? Especially in patients who are already sick, maybe already have abnormal chest x-rays.
That's the challenge. Clinical recognition really requires integrating multiple pieces of information: radiological findings, systemic signs of infection, and ideally, microbiological data.
What are the core findings we look for?
Well, the absolute requirement is a new or clearly progressing infiltrate on chest imaging X-ray or CT scan. That's number one.
Okay.
But that alone isn't enough. It has to be coupled with clear evidence of an infection causing it.
Which means?
Typically things like new onset fever or sometimes hypothermia and severe sepsis, an elevated white blood cell count, leukocytosis, or sometimes leukopenia, the production of new or worsening purulent sputum thick colored stuff, and often worsening oxygenation or needing more ventilator support.
So infiltrate plus systemic signs.
Correct. Although it's worth noting, especially in older, maybe frail patients, the presentation can be more subtle.
Also,
You might just see altered mental status, confusion, or maybe unexplained new weakness. Sometimes that's the only early sign, so you need a high index of suspicion in those groups.
okay. And for VAP, are the criteria even more specific?
They are, yes. The diagnostic criteria are quite tightly defined for VAP. You need that new infiltrate appearing at least 48 hours after intubation,
Right.
plus at least 2 of the following specific signs: fever over 38 Celsius or hypothermia below 6, an abnormal white count, high or low, and purulent tracheal secretions.
So that cluster of findings points strongly towards VAP.
It guides the diagnosis, yes, but then the immediate next step is assessing severity, because that dictates where the patient needs to be treated.
Absolutely. Any patient with suspected HAP or VAP who looks really sick, severe hypoxemia, hemodynamically unstable, signs of organ dysfunction like septic shock, they need to be in the ICU, period.
Regardless of where they started, their mortality risk is just too high. They need aggressive resuscitation and monitoring alongside the antibiotics.
Okay, so suspicion is high, patient is potentially very sick.
Yeah.
What's the very first step in terms of diagnostics?
Critical first step, absolutely non-negotiable. Get cultures before starting antibiotics. Respiratory samples and blood cultures.
Why is that sequence so important?
Because antibiotics, even a single dose, can rapidly sterilize cultures or at least reduce the bacterial load below detectable levels. If you give antibiotics first, you might never know what you're actually treating. You lose the chance to target therapy later.
Right, so samples first. What kind of respiratory samples are we talking about?
The guidance from IBSA and the American Society for Microbiology generally favors starting with the least invasive approach that gives you a good quality sample.
So for a non-ventilated patient with HAP.
That usually means getting a good quality expectorated sputum sample. Ideally, you'd look at a Gram stain first to make sure it's actually from the lower airways, lots of white blood cells, few squamous epithelial cells, and see if there are predominant organisms.
And for a ventilated patient, VAP suspicion.
For VAP, the preferred non-invasive sample is an endotracheal aspirate, or ETA. That's obtained by suctioning secretions directly from the endotracheal tube. It's easy to get and generally representative.
How useful are these non-invasive samples? Can we trust them?
They can be very useful, especially for ruling out infection. If you get a good quality sputum sample or ETA, and the Gram stain shows no inflammation, and the culture grows nothing significant, that has a pretty high negative predictive value.
Meaning it makes pneumonia less likely.
Exactly. It might support watching and waiting or looking for other causes of the patient's symptoms, or even stopping antibiotics if they were started empirically. That's key for stewardship.
Okay, But what about the more invasive stuff?
No.
Bronchoscopy with BAL, bronchoalveolar lavage, or a protected specimen brush, PSB?
Right. The guidelines generally don't recommend routine use of these invasive techniques up front.
Why not?
Well, mainly because they require more resources, expertise, they carry some procedural risk, and they take time. The recommendation is usually to reserve them for specific situations, such as the critically ill patient who isn't responding to initial empiric therapy after, say, 48 to 72 hours. Or maybe if the non-invasive samples are really unhelpful or suggest something unusual is going on, like fungal pneumonia or an opportunistic infection.
So it was more of a second-line diagnostic strategy when the initial approach isn't working.
Exactly. Maximize the yield when you really need more specific information.
Now, when we get these samples, especially the ETAs or BALs, we often talk about quantitative cultures. Why is the quantity important?
That's a really crucial concept. Quantitative cultures help us distinguish true deep-seated infection from just colonization of the airways.
Because the upper airways and the ET tube itself are often colonized with bacteria, right?
Absolutely, especially in hospitalized or ventilated patients. Just growing some bacteria doesn't automatically mean it's causing pneumonia. Quantitative cultures set specific thresholds for the bacterial load.
What are those typical thresholds?
They vary slightly by sample type. For an ETA, the threshold suggesting infection is generally higher, typically O10 ENOR, so 100,000, or even 10 ERA, 1 million colony-forming units per milliliter, CFU/ml.
Okay.
For a BAL fluid sample, which is obtained from further down and is less contaminated, the threshold is lower, usually O10 OAA CFU/ml.
And for the protected specimen brush, PSB.
That gets the deepest, least contaminated sample, so the threshold is the lowest, typically O10 AFE AFU/ml.
And these numbers aren't just pulled out of thin air, right? They're based on studies correlating bacterial load with clinical infection.
Exactly. They're validated thresholds. Using them helps prevent us from overtreating colonization, maybe someone who's febrile for another reason, like DVT or drug fever, but happens to have some bugs in their airway. It's another stewardship tool.
Makes sense. What about newer technologies? Are there faster ways to get diagnostic information?
Yes, definitely. Rapid molecular diagnostic panels, sometimes called syndromic panels, are becoming much more common, especially in ICUs.
How do they work?
They use PCR-based techniques to simultaneously detect genetic material from a range of common bacterial and sometimes viral pathogens, and often key resistance genes like MECA for MRSA or genes for carbapenemases like KPC.
And the advantage is speed.
Huge advantage in speed. You can potentially get results identifying a pathogen and major resistance markers within hours instead of the days it takes for traditional cultures to grow and have sensitivities run.
How does that impact management?
It can allow for really rapid tailoring of antibiotics. For example, if a patient is started on broad coverage, including vancomycin and piperacillin tazobactam, and the panel comes back positive for Pseudomonas but negative for MRSA,
you can stop the vancomycin much sooner.
Exactly, within hours, potentially. It accelerates de-escalation and optimizes therapy much faster. That's a significant stewardship win.
Okay. What about biomarkers, things like procalcitonin or C-reactive protein? Where do they fit in?
They can be helpful adjuncts, but they should never replace the microbiological workup.
Why not?
Because they're not specific for pneumonia, especially in critically ill patients who often have inflammation from many sources. CRP is very nonspecific. Procalcitonin is a bit better.
How is procalcitonin useful?
It tends to rise more significantly in response to bacterial infections compared to viral infections or non-infectious inflammation. So a very low procalcitonin might argue against bacterial pneumonia. More importantly, tracking its trend downwards can be very helpful in guiding decisions about when to stop antibiotics.
So using it for de-escalation.
Yes, there's good evidence supporting procalcitonin-guided algorithms for shortening antibiotic duration safely. Some studies also suggest that combining clinical scores, like the Clinical Pulmonary Infection Score, or CPIS,
which includes things like temperature, white count, oxygenation.
Right. Combining CPIS with a procalcitonin level, maybe above 0.5 nanograms per milliliter, might improve the overall diagnostic accuracy for HEVAP, but again, it's supportive, not definitive.
Okay. So we've suspected pneumonia, we've assessed risk, we've gotten our cultures, now we need to treat.
Yeah.
What's the key principle for starting empiric therapy?
Timeliness. It's absolutely critical. The data is overwhelming. Delays in starting appropriate antibiotics for patients with severe HAPAP, especially those with sepsis or shock, significantly increase mortality. Every hour counts.
So once cultures are sent, get the first dose in promptly.
As soon as reasonably possible. The choice of which antibiotic, though, goes right back to that MDRO risk stratification we talked about.
Right, let's break that down. Low-risk patient first. No recent IV antibiotics, not ventilated, hemodynamically stable.
For that patient, the guidelines recommend standard spectrum agents. Often, monotherapy is perfectly adequate.
Like what?
Maybe a non-pseudomonal third-generation cephalosporin like ceftriaxone, or possibly a respiratory fluoroquinolone like levofloxacin or moxifloxacin, though we always worry a bit about quinolone resistance pressure.
And MRSA coverage.
Generally reserved only if the patient has a known history of MRSA colonization or infection, or if your local hospital or unit has a particularly high prevalence of MRSA causing HAP. Otherwise, you typically wouldn't cover it empirically in this low-risk group.
Okay, now shift gears to the high-risk patient. Septic shock, needing ventilation, recent broad-spectrum IV antibiotic.
Here, the approach has to be broad-spectrum coverage right out of the gate. We absolutely must cover Pseudomonas aeruginosa, and we must cover MRSA empirically.
And this is where the idea of using 2 drugs for Pseudomonas comes in sometimes.
Exactly. For patients considered at high risk of mortality, which generally includes anyone in septic shock or needing mechanical ventilation, or those with recent IV antibiotic use where resistance is more likely, the IDSA guidelines recommend initial therapy with 2 anti-pseudomonal agents from different antibiotic classes.
Why 2? Is it for synergy?
Not primarily synergy in the classic sense. It's more about increasing the probability that at least one of the drugs will be active against the Pseudomonas strain, especially if it harbors resistance mechanisms that we don't know about yet. It's a probabilistic bet to ensure adequate initial coverage.
What would be a typical combination?
You'd usually pair an anti-pseudomonal beta-lactam like piperacillin-tazobactam, cefepime, ceftazidime, meropenem, or imipenem with a second agent from a different class.
Like an aminoglycoside?
Yes, like amikacin, gentamicin, or tobramycin. Or sometimes an anti-pseudomonal fluoroquinolone like ciprofloxacin or levofloxacin.
So maybe cefepime plus amikacin or piptazo plus cipro.
Those are common combinations. The choice might be influenced by local resistance patterns, patient allergies, kidney function, and prior antibiotic exposures. For example, cefepime might be preferred over ceftazidime if ESBL risk is high.
And then you add MRSA coverage on top of that.
Yes. In these high-risk scenarios, you'd add vancomycin or linezolid empirically until MRSA is ruled out by cultures or rapid diagnostics.
Okay, so that's very broad initial coverage, but it sounds like a potential recipe for antibiotic overuse, if we're not careful. How does stewardship fit in here?
Stewardship is absolutely integral to this whole process. You can't just start broad and forget about it. That initial broad coverage is meant as a bridge, a safety net.
We need proof that stewardship actually works without harming patients, right?
We do, and we have it. Studies like the INSPIRE trial are really important here. INSPIRE was a randomized controlled trial looking specifically at stewardship interventions for HPVP.
What did it show?
It demonstrated very clearly that using things like computerized decision support prompts built into the EMR based on risk factors, along with education for clinicians, could significantly and safely reduce the unnecessary empiric use of broad-spectrum antibiotics, particularly anti-pseudomonal agents and MRSA coverage, in patients who are actually low risk.
So stewardship helps us apply that risk stratification more effectively.
Exactly. It's not about restricting necessary drugs. It's about ensuring the right drugs are used for the right patient at the right time and, importantly, for the right duration.
Okay, let's talk about duration. How long do we typically need to treat HAP or VAP? Has that changed over time?
It really has. The pendulum has definitely swung towards shorter durations of therapy for many patients.
What's the standard now?
For uncomplicated HAP or VAP, meaning the patient responds well clinically, clears any bacteremia quickly, is immunocompetent, the standard recommended duration is now typically 7 days.
7 days, not 10 or 14.
Not routinely, no. Multiple meta-analyses and trials have shown that for appropriately selected patients, a 7-day course is just as effective as longer courses, but with potentially less risk of side effects, C, disinfection, and promoting resistance. Sometimes even 5 to 7 days might be enough for rapid responders.
So less is often more, provided the patient is doing well.
That's the principle. However, there are definitely exceptions where longer courses are still needed.
When would we need to treat for longer, say up to 14 or 15 days?
Longer durations are generally reserved for a few specific situations. One is the patient who is a slow clinical responder. Maybe their fever lingers, oxygenation improves slowly. Another is infection caused by certain difficult-to-treat organisms, particularly non-fermenting gram-negative rods like Pseudomonas or Acinetobacter.
Why longer for them?
They just seem to be harder to eradicate completely, and relapse rates might be higher with shorter courses. Also, patients with documented bacteremia associated with their pneumonia, or those with underlying structural lung disease like cystic fibrosis, or complications like lung abscess or empyema often require longer treatment.
Makes sense. But regardless of the planned initial duration, reassessment is key, right?
Absolutely critical. At the 48 to 72-hour mark, you must reassess. Look at the culture results that are coming back. Look at the patient's clinical trajectory. Is the fever resolving? Is oxygenation improving? Are inflammatory markers trending down?
And based on that?
Based on that, you de-escalate. Narrow the antibiotic spectrum based on sensitivities. If MRSA wasn't found, stop the vancomycin or linezolid. If Pseudomonas wasn't found, maybe narrow the gram-negative coverage. If the patient is improving rapidly, confirm the plan for a shorter duration. This reassessment and de-escalation step is maybe the single most important part of antibiotic stewardship in HEVA management.
Okay. Beyond the antibiotics, what about supportive care?
Hugely important, often just as important as the antibiotics. This includes optimizing oxygenation and ventilation strategies, lung protective ventilation if they're on the vent, careful fluid management, avoiding overload but ensuring adequate resuscitation, hemodynamic support with vasopressors if they're in shock.
And continuing efforts to prevent further complications.
Yes, things like stress, ulcer prophylaxis, DVT prevention, nutritional support, and ongoing attention to minimizing further aspiration risk, keeping the head of the bed elevated, managing secretions. It's comprehensive critical care.
Given how difficult and dangerous these infections are to treat, prevention seems like it should be a major focus.
Absolutely. Prevention is arguably the highest yield intervention we have. A multifaceted approach, often using bundles of care, is essential.
Let's break that down. First, preventing non-ventilated HAP and VHAP. What works there?
Two big areas: oral care and aspiration precautions. The evidence for oral care is becoming quite strong.
What kind of oral care?
Specifically, regular mechanical plaque removal, actually brushing the patient's teeth. Multiple systematic reviews now show that routine toothbrushing significantly reduces the incidence of NVHAP.
Just basic toothbrushing. What about antiseptic mouthwashes like chlorhexidine?
That's more controversial now. While chlorhexidine has been widely used, the evidence supporting its benefit for preventing HAP specifically is inconsistent. Some studies show no benefit, and there are even concerns about potential harms, like promoting resistance or oral irritation.
So the focus should really be on the mechanical cleaning.
Yes, the primary recommendation is diligent, regular toothbrushing to reduce the bacterial burden in the mouth.
Okay, and the other part was aspiration reduction.
Right. This involves several things. Consistently keeping the head of the bed elevated, ideally 30 to 45 degrees, especially if the patient is receiving tube feeds. Implementing standardized protocols for swallowing assessments, particularly in high-risk patients like those post-stroke or with neurological impairment. Screening for dysphagia, and trying to minimize sedation whenever possible to help maintain protective airway reflexes.
And what about getting patients moving? Does mobility help?
Yes, absolutely. Early mobilization protocols are increasingly recognized as a key component of HAP prevention. Getting patients out of bed, walking if possible, even just sitting up in a chair, helps improve lung expansion, clears secretions, and reduces overall risk. It's really essential.
Okay, so that's for NVHAP. Now, for preventing VAP in ventilated patients, we often hear about the VAP bundle. What are the core elements there?
The VAP bundle elements have evolved slightly over time, but the core principles remain. Head of bed elevation, 30 to 45 degrees, is still fundamental.
What else?
Using endotracheal tubes that have a special port for subglottic secretion drainage, sucking out those pooled secretions above the cuff, has shown significant benefit in reducing VAP rates.
That makes sense, targeting that key mechanism we discussed.
Exactly. Other elements include minimizing how often the ventilator circuits are changed, as breaking the circuit can introduce contaminants, using closed suctioning systems instead of open suctioning, and just meticulous daily assessment of readiness to wean from the ventilator, minimizing duration of ventilation. Plus, general critical care best practices like prompt removal of unnecessary lines and catheters.
Okay. Now, there's one more prevention strategy that's often discussed, but quite controversial. Selective digestive decontamination, or SDD.
Ah, yes, SDD. This involves giving topical, non-absorbable antibiotics, usually a paste or liquid applied in the mouth and sometimes down an NG tube, often combined with a short course of IV antibiotics.
What's the goal?
The goal is to suppress or eradicate potentially pathogenic bacteria and yeast colonizing the oropharynx and stomach, thereby reducing the reservoir of organisms that could be aspirated and cause VAP.
Does it work?
Well, numerous studies, particularly from Europe, have shown that SDD can significantly reduce VAP rates, and some studies even show a reduction in mortality, especially in high-risk ICU populations.
So why is it controversial? Why isn't everyone doing it?
The major concern is antimicrobial resistance. Widespread use of topical and systemic antibiotics for prophylaxis raises significant fears about selecting for highly resistant bacteria within the ICU environment.
Especially in places where MDROs are already common.
Exactly. The risk-benefit calculation looks very different in an ICU with high rates of MRSA, VRE, or CRE compared to one with low baseline resistance. Because of this concern, SDD is generally reserved for specific settings, usually those with low endemic resistance rates, and it requires very careful institutional consideration, implementation protocols, and ongoing resistance surveillance. It's definitely not standard practice everywhere, particularly in the U.S.
Okay, so a complex picture on prevention. Let's shift now to the potential complications if HAP or VAP does occur, and the overall prognosis. What are the main bad outcomes we worry about?
Well, the most immediate and severe pulmonary complication is progression to acute respiratory failure, often requiring mechanical ventilation if the patient wasn't already on it, or worsening ventilator dependence. This can rapidly evolve into full-blown ARDS, acute respiratory distress syndrome.
And ARDS itself carries a very high mortality.
Extremely high. Other local pulmonary complications can include developing an empyema pus collecting in the pleural space, which usually requires drainage with a chest tube and sometimes clot-busting drugs.
Fibrinolytics.
Right. Or the infection can wall itself off and form a lung abscess, which typically needs very prolonged antibiotic courses.
And what about systemic complications outside the lungs?
HAP and VAP frequently trigger a systemic inflammatory response, leading to sepsis and potentially septic shock. This can cause multi-organ dysfunction. Acute kidney injury needing dialysis is very common. Thromboembolic events like DVT or PE are also increased.
Any impact on the heart?
Yes, significantly. Acute cardiac events, including non-ST elevation messes and STEMIs, are more frequent. And there's data specifically showing that HAP is independently associated with worsening acute heart failure. One study found a hazard ratio of about 1.86 for increased mortality in heart failure patients who developed HAP.
So it really destabilizes the entire patient.
Profoundly. Which leads us to the overall prognosis and mortality.
Which we touched on earlier, but let's revisit. It's pretty grim, isn't it?
It really is. HAP and VAP are associated with substantial short-term and long-term mortality. Even for patients who survive the initial hospital stay, the battle isn't over. One-year mortality rates after HAP or VAP are reported in the range of 35% to maybe 41%.
Wow, over a third of survivors don't make it a year.
It's a marker of severe illness and often underlying frailty. These are often life-altering events with long-term consequences for function and survival.
And does the type of bug matter for prognosis?
Absolutely. As you'd expect, infection with MDROs significantly worsens the prognosis. When the culprit is one of the highly resistant gram-negatives, particularly carbapenem-resistant organisms like CRE,
the mortality rates skyrocket.
They do. In-hospital mortality in cases of CRE pneumonia often exceeds 46%. It just highlights why getting that initial empiric therapy right, especially in high-risk patients, is so critical.
When we're rounding on these patients day to day, what factors should make us particularly worried about their prognosis? What are the strong predictors of a bad outcome?
There are several well-established predictors. Clinically, advanced age is consistently a risk factor. Pre-existing chronic kidney disease, severe immunosuppression, like being on high-dose steroids, factors indicating high aspiration risk, and radiographically having multi-lobar infiltrates at presentation suggests a larger burden of infection and predicts worse outcomes.
Those are mostly baseline factors. What about how the patient responds to treatment?
That's probably the most immediate and actionable predictor we see on rounds. How is the patient doing within the first 72 to 96 hours? If there's a lack of clinical improvement, their oxygenation isn't getting better, fever persists, markers of organ dysfunction aren't resolving or are worsening, that's a very strong predictor of higher mortality.
And that signals a need to really reevaluate everything.
Absolutely. It mandates an immediate pause and rethink. Do we have the right diagnosis? Did we miss a resistant organism? Do we need broader coverage? Is it time for invasive diagnostics like a bronchoscopy? Is there a complication like emphysema? That lack of early response is a critical decision point.
Okay, so we've covered a lot of ground here, from the nuances in defining NVHAP versus VHAP to the critical importance of MDRO risk stratification.
Right, through the diagnostic strategies emphasizing non-invasive sampling first, understanding quantitative cultures, and using rapid diagnostics wisely.
To the principles of empiric therapy, balancing broad initial coverage with rapid de-escalation based on that crucial 48-72-hour reassessment.
And, of course, the power of prevention bundles oral care, aspiration precautions, VAP bundles trying to stop these infections before they even start.
I think the core message, clinically, remains that delicate balance, doesn't it?
Yeah.
We need prompt, aggressive, appropriate empiric coverage for those high-risk patients because delays kill.
We absolutely do.
But at the same time, we have an equally vital responsibility to rapidly de-escalate based on culture data and clinical response. We can't afford to miss the bad bugs, but we also can't afford the consequences of rampant antibiotic overuse.
That tension, that balance, is really the art of managing HAP and VAP effectively and responsibly. It's a daily challenge on the wards and in the ICU.
And we know from lots of data that general severity of illness scores, things like SOFA, APACI-2, are very powerful predictors of who's going to do poorly, who's likely to die from critical illness, including VAP.
Incredibly strong predictors, yes.
So thinking about that and considering the persistently high mortality we've discussed, here's maybe a final thought or question for listeners to ponder. How should we, ethically and practically, integrate these validated prognostic scores that tell us a patient is at extremely high risk of dying anyway, into our decisions about antibiotic de-escalation, especially for those complex patients who aren't responding well after a few days?
That's a tough one.
It is. How do we balance the risk of potentially undertreating a devastating infection in someone we know has a very poor prognosis overall against the broader societal imperative of antimicrobial stewardship and avoiding unnecessary antibiotic pressure? Where does patient-centered prognosis meet public health responsibility in that difficult scenario?
Yeah, that's a really challenging ethical and clinical dilemma. There's no easy answer, but it's something we grapple with constantly at the bedside.
Definitely something for all of us in hospital medicine to continue thinking about.
Indeed. Well, this has been a great deep dive. Thanks for the discussion.
Thank you for joining us on the Hospital Medicine Unplugged podcast.